Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of radiation-induced lymphangioma circumscriptum-like atypical vascular lesion of the vulva. So this is a case of a 63-year-old female patient who received radiotherapy long ago for vulva carcinoma. Now, she presented with what was described as thickening at the surgical scar. And as you can see here from the low power magnification, it was an excisional biopsy, and there are many dilated vascular spaces that are variably sized, involving the dermis from the superficial part down, very down, going deep into the dermis. On high power magnification, as you can see, there is this proliferation that is causing elevation of the epidermis, or what we call interepidermal growth of the blood vessels or of the vascular proliferation. And here more on high power magnification, this is the epidermis, and these are the endothelial cells lining the stretched out vascular space that is containing fibrin. In other areas, you can see here, for example, the variably sized dilated vascular spaces, again here lined by hook-nailed endothelial cells, and going really from the superficial dermis in between the epidermal papillae down into, or the ridges down into the deeper parts of the dermis. Scattered cells with kind of smudged nuclei were seen. These are the residue of the previous radiotherapy that the patient was exposed to. And again, these are the vascular spaces lined by those minimally atypical cells. And this is actually one high power magnification of the deeper part of the lesion, where we still can see the vascular spaces, the dilated vascular spaces here going really very deep, dissecting in between, approaching almost the subcutaneous fat. And it's very important to bear in mind that because of the history of radiotherapy in this patient, we have a differential diagnosis of either atypical vascular proliferation or lesion versus angiosarcoma, which is the single most important differential diagnosis. And this is the immunohistochemistry. ERG is a nuclear stain, a nuclear vascular marker. And as you can see here, this is the epidermis, and this is the interepidermal component that is causing the elevation of the epidermis and replacement of the dermal papillae by the vascular space. And D240 is a lymphatic marker. So this is in support that the vascular proliferation is not venous or a capillary, it's rather lymphatic. This is another area where we have more like the irregular shaped vessels and the dissection down deep into the dermis. And again, with the D240, this is the D240 is cytoplasmic staining, and it's beautifully decorating the vascular space or the lymphatic space that is causing the lesion. And this is going deep into the dermal component, again with the ERG, the nuclear staining, supporting that this is a vascular lesion, and then the D240 cytoplasmic staining in support of the lymphatic nature of the proliferation. Now, c-MYC is very important here because the differential diagnosis of angiosarcoma, the c-MYC would usually be positive, showing a nuclear stain. Now, surprisingly, the normal control, the normal non-neoplastic control for the c-MYC immunohistochemistry is the normal squamous epithelium. So this is the normal squamous epithelium showing the nuclear stain. This is non-mutant. This is the normal pattern. We're looking here for the endothelial cells lining the dilated vascular spaces, which are at large negative, thus in a way ruling out angiosarcoma. Another important marker that we can use in this differential diagnosis is the Ki-67 proliferative index. And as you can see here, this is the basal layer of the epidermis showing some proliferative activity, as is the usual normal case, while the endothelial proliferation is completely silent. There is no evidence of proliferation. And this is the deeper component that we're seeing deep in the dermis, completely negative for Ki-67. So to sum up, the final diagnosis is radiation-induced lymphangioma circumscriptum-like atypical vascular lesion of the vulva. This is a non-proliferative lesion that can be seen post-radiotherapy, most commonly in the breast, but in other areas where radiotherapy is administered, very rarely reported in the vulva. It's very important to keep in mind this possibility of the differential diagnosis in order not to misinterpret the case as angiosarcoma. Clinically, the lymphangioma circumscriptum lesions, whether this is a primary lymphangioma circumscriptum or secondary radiation-induced lymphangioma circumscriptum, can be misinterpreted clinically as something like a vesicular disease like herpes gestations, for example, or herpes simplex infection of the skin of the vulva. Remember that although this is a benign lesion, completely benign lesion, rarely reported in the literature to progress to angiosarcoma. A single case report, I think, which I saw when I did the literature review. In general, these are completely benign. However, they might recur if incompletely excised, especially that the surgeon at the time of excision are not aware usually of the nature of the lesion that he or she is excising, and the really breadth and depth of the vascular proliferation. This is why usually quite often these lesions are incompletely excised. However, remember that these lesions, although they have this atypical appearance, they are completely benign, so should not be misdiagnosed as angiosarcoma. I hope you find this tip useful in your daily practice. Thank you.